welcome everybody to the 43rd virtual shadowing session. Tonight, we're doing a specialty spotlight for cardiology. You can find us on Instagram, YouTube, and on virtualshadowing.com. Here is our team here. We have Reagan, myself, Cheyenne, Taylor, Alana, Rachel, Anirudh, Mariam, Rohit, of course, Dr. Fowler, Dr. Morchetti, Dr. Salazar, and Dr. Reno. So that is our team. So next week we have another session for a specialty spotlight in orthopedic surgery with Dr. Sloan. And you can join us on Zoom or YouTube Live at 7 p.m. Central Standard Time. And we will release another announcement about the April sessions very soon. And as always, if you have any questions throughout the session tonight, please feel free to put it in the Zoom chat or the YouTube live chat if you're watching from there. And we'll do our best to get to those questions as we get to the question and answer session.
Welcome everybody to Virtual Shadowing, all 330 of you. It's so good to have you. Today we crossed over 40,000 of you that have signed up to be with us in the last 10 months. And we're so very delighted to have you be part of this program from whatever direction that your decision for healthcare studies will take you. This has been an exceptional time, and we want to we'll be coming up on a year in June, and we would like to kind of get a hint from you if you would like us to keep going. By that time, we'll have over 50 lectures posted online, but if you want us to keep going, you just please let us know and send us emails and all that sort of thing. And I see all the lines in chat coming through. But anyway, we're so glad to have you. You're part of the virtual shadowing family. And I guess as long as you keep coming, we'll keep coming back. So Cheyenne, we have two absolutely marvelous guests tonight. And would you please introduce them?
Of course. So we have two renowned cardiologists joining us tonight. The first is Dr. Nesbitt, and she's a professor in the Department of Internal Medicine at UT Southwestern. We are also joined by Dr. Solistio, who is an associate professor of medicine in the Department of Internal Medicine's Division of Cardiology at UT Southwestern. So we are very excited to have them here tonight with us, and I will give it away to, oh, that was for later. I will give it away now to Dr. Nesbitt for her presentation.
All right. Thank you so much for the invitation to speak. When Reagan reached out to me and Dr. Fowler to ask me to do this, I was excited that you were doing something during COVID that engaged the audience that we so need to generate the next generation of physicians and care providers. And so we're really esteemed to do this. But I thought, wow, what an opportunity to bring my best buddy with me and my colleague, Dr. Solistio, because we get to work together in two different domains. And I thought we do different things in the same space, but it would allow you to understand that cardiology and cardiovascular medicine is a broad field, and there are lots of different things that you can do within this one particular aspect of medicine. So I'm going to share my slides, and Dr. Solistio and I have put together a dynamic presentation for you tonight, filled with our personal journeys, as well as more about two cases actually that we've put together that demonstrate the breadth of what we do. So I will start talking with you about my pathway to medicine, a journey in hypertension, as I like to think of it. And so I'll start from the very beginning, because I think that everybody needs a why. Why do you do what you do? Because your why is what will inspire you for the rest of your life. These are the people that are my whys. They are all my whys because they're all my family. And everyone on this picture are people who suffered from hypertension. And most of them have passed away from some aspect of hypertensive effects, either strokes or heart attacks or kidney disease as well. As a little child growing up, I thought that's the only reason people go to the doctor. So if I want to take care of people, that's what I'm going to actually be taking care of. I never knew that I could focus on hypertension. So yes, that's me. I grew up in a small town outside of Pittsburgh called Aliquippa. And yes, it was a steel town. All the steel mills were all around me, pretty smoky most of the time. And of course, we love the Steelers, and the Penguins and the Pirates were all very successful during my time there. And that is me in ninth grade with, yeah, big hair, the big glasses, and you can't see them, but my initials are on the side of my glasses because that's what we did at that time, and a popped collar because that made me cool. But at that time, I knew in my heart that I wanted to be a doctor. And I had that conversation with my parents multiple times, although I had no doctors in my family. I had no one who had actually even gone and completed college by this time in my life. So it was in a lot of ways a bit of a pipe dream, but I knew that that was what I wanted to become. So off I set to find my desire. But along the way, there are lots of things that you will do. Oh, the places you will go. Yes, I was a Burger King girl. I worked at Burger King in the 70s, late 70s and early 80s through high school, and then between my college years. And yeah, that's the Empire Strikes glasses that we sold along with your Have It Your Way burger. No, these girls are not me singing. But Burger King had a lasting effect on me. And I wanted to put it there because I wanted you to realize is that regardless of where you are and what you are doing right now, your future is bright. And where you are now has no determination of where you are going to go. I did not know where I would go from Burger King with that ugly orange and yellow outfit on and the hat too. But people will affect your destiny. And you should realize that all of the people around you will have an effect on your destiny, and you have an effect on others' destinies. Remember that, because whatever you do and you touch other people, you can change where they go as much as they change your destiny. So this is not me, but my dentist had a profound effect on my life as a young person. As I said, I had no one else in my life who was a physician or a scientist, but my dentist took an interest in my brother and I and asked us while he's operating on our teeth what we were going to do, and then allowed us to shadow him in his office and his wife, who was also a dentist. And they took us to the University of Pittsburgh to see what dental school would be like and give us the window on how you get there. It was the first time that I had any idea of what the trajectory was that college needed to follow with professional school and then perhaps a residency. I did learn a lot. I understood what it meant to go through professional school, but I also learned that I did not like teeth and I did not want to work in anyone's mouth. Very strong lessons. So from there, I went to college. And I went to a small college in Erie, Pennsylvania called Gannon University. Yes, this is me here with my best girlfriends from my undergrad school. I went there because they had an accelerated program that connected from this small college to a medical school in Philadelphia and a direct track. And if you were successful in the 3 years that you were there and met the certain standards that they were looking for, they had a selection a year early, and they would select you to start medical school 1 year before you graduated from undergrad. And I was selected to be in that group. So out of the 80 students who started out with me, 10 were selected, and I was the very first African-American to be selected to start medical school after my third year from that program. And so off I go to the city of brotherly love, to Philadelphia, which was at the time that I went there was Hahnemann Hospital, and Hahnemann Medical School is now known as Drexel Medical School. But at the time, it was a medical school located in the center of Philadelphia and took care of a large component of the indigent population in Philadelphia, and really was a fabulous experience for me. In many ways, I learned a lot by being there, not only from medical school, but just the experience of being in the city at that time. From there, I finished and came back to Pittsburgh to do my residency at Allegheny General Hospital, which is a large community hospital affiliated with then Hahnemann. And I did my internal medicine residency there. And as I was finishing my third year of residency, my then nephrology attending asked me what I would do. And I said, I owe a lot of money and my parents can't afford to pay back my loans. So I'm going to go work. That was pretty obvious to me, but I'm really happy to go work because this is what I wanted to do. And he said to me, you should never forget that you live your life by passion, not by finance. If you live by passion, you will always be excellent and finance will always follow you. And so your passion is hypertension. So follow your passion and you need not worry about the finance, which I thought was incredibly brilliant. And I've never forgotten that statement because it always makes me think about what it is that I really want to do.
Hey, Shauna, Shauna, one of our students just said, after you said that quote about the money following you, I just found my senior quote.
I love it. I love it. I'm good for something. So you at least one person learned something. And that trek took me to the University of Michigan, where I did my fellowship focusing on hypertension. I met some wonderful people there who were doing research, and that introduced me to doing clinical research, what it was all about. I stayed there for a total of 10 years. I got a master's degree from the School of Public Health while I was there, learned how to run clinical trials, ran some clinical trials with patients all around the world, did a lot of traveling with my presentations, and had a phenomenal time there. That is my daughter, who is now a senior in college, who was just born while I was in my master's program there. From there, I was recruited to come to UT Southwestern, and I've been at UT Southwestern since 2001, where I first take care of patients both at UT Southwestern clinics, at Parkland Hospital. I run the hypertension clinic there as well. I've been very lucky to be a participant and a leader in clinical trials. This was our trial, the trophy study that we did was published in the New England Journal, and I've received some accolades from the Allstate Insurance Company for being a history maker and listed in a calendar for 2004. So since then, I've been able to present my research. This is me in Spain last year, or year before last, actually, presenting with my colleagues from Michigan and around the world. But really, my heart lies in another direction because hypertension will always be a part of what I wanted to do and what I will never stop doing. But the second love I have is really shepherding and mentoring students to get to the destination of their desires. And so in 2011, I became an associate dean in the Office of Student Affairs, specifically in student diversity and inclusion. I've mentored many students from high school, and some of them have now graduated and gone off to do their own residency programs, but it gives me great pride to be able to give back some of what others have poured into me. This is really full circle for me, is that I can give someone else the same opportunity that someone gave to me early. So what do? I'm an academic physician. I'm a professor. I am board certified in internal medicine. I'm a hypertension specialist, a fellow of the American Heart Association. I sit on the American Heart Association board now locally and have participated in grants reviews, both nationally as well as in the American Heart Association. I'm an associate dean of student affairs. I take care of patients. I have a couple of research trials that I run. I teach the medical students, and I have administrative roles. And I'm a wife and a mom. And those are all of my big roles that I am happy to do every day. Am I tired? Yes, but I'm happy. And I think that's what matters in life. So I'm going to stop here and stop share and turn things over to my colleague, Dr. Celestio, so that she can share her journey. Mel?
Yes, thank you so much, Shauna. Dr. Nesbitt, I got to tell you, when Dr. Nesbitt asks you to do something, you don't just say yes. You say, okay, yes, and how did I even get so lucky that you asked me? Because as you guys can clearly see, she's amazing. I think she's amazing. She's actually someone that I look up to, and I try to learn from every single day. So thank you, Dr. Nesbitt, for asking me, and thank you guys for having me here. I'm going to share my screen now and hopefully not mess this up. I will tell you that I could very easily have a whole conversation with Dr. Nesbitt right now and literally just ask her things about her time at Burger King. But I'm not going to do that to you guys. I'm not going to do that to you guys. I'm trying to make it so I can see your faces, but I don't know that that's going to work because I have multiple screens going on here. So I'm going to go ahead and get started here. And you know, Dr. Nesbitt and I had different paths, but I think what I love about this is that just like she said, that we are giving you two different kind of fields for how you can traverse through medicine and head towards a career in dealing with heart disease and hypertension and cardiovascular risk factors, et cetera. So that's my big picture. So yes, I don't look like this all the time. You know, as Dr. Nesbitt was talking, I think both of us wear a lot of different hats. And so I just am going to do a really quick overview of some of the different hats that I wear. Before I even do that, though, there's one more thing I have to say about Dr. Nesbitt. There was a question that came up in the chat that said, where does your daughter go to school? And I'm sorry, Dr. Nesbitt, but I'm just going to brag real quick. Because Joy not only goes to Harvard, yes, you heard that right, Harvard, but she is already famous and she's already doing incredible things just like her mama. So I just want you to know that. Okay, so this is myself and of course, Dr. Nesbitt. This is during one of the Go Red days. So during the month of February, where we're teaching about women's heart disease and heart health. And so this is in her office. I just had to share that. So I am a cardiologist. I do take care of patients with heart disease or people at risk for heart disease. And I get to work with the awesome woman that I just mentioned. I'm also an educator. So I pride myself in having a large focus on medical education. One of the things that I knew from the get-go was not only did I want to take care of patients, but I also wanted to have the opportunity to influence the future of medicine as well, which is a great honor. It's funny for me to say this, but apparently I'm also a researcher and author. I still don't believe it, to be honest. And I actually think it's, I kind of giggle underneath whenever I say this because it's hard for me to believe this. But as I have gotten into medicine and not only gotten into medicine, but became faculty, I found areas of passion where I also wanted to provide new knowledge and discover new knowledge. So I have published, just like Dr. Nesbitt was talking about, and authored a few things. I'll talk about that in a little bit. This is the other hat that I wear, not literally the hat in graduation, but another hat that I wear that I get to work with Dr. Nesbitt is that we are both Associate Deans for Student Affairs. And this was a moment that I was able to sit between two of my favorite people, Dr. Nesbitt and Dr. Kareem Abdul Fattah, who is the program director of surgery. So we get to work with some just fabulous medical educators. And then finally, I cannot leave out that I am also a wife of a physician. That is my husband, Eric Staley. And I am also a mom. I'm a mom of 3 kids who are now, I can't believe this, 14 and 11 and 3, almost 4. So I've got a wide range of ages here. So these are just some of the hats that I wear. Let's see here. So let me start from the beginning. You may not want me to go back this far, but I'm going to go there. But this is really relevant to my story here. So these are pictures of my parents. And I'd like to just tell you a little bit about them just because they have had such a huge influence on who I am today and what I'm doing today. On the top left corner, this is a picture of my mom and her, I didn't even count here, but she has 8 brothers and sisters, or had 8 brothers and sisters, some of them have passed. She is the one at the bottom who is kind of kneeling, sitting, and she's second from the left. And just above her is her mother. Now, why do I show you this? My mom was born and raised in the Philippines. She was actually born and raised there because her parents fled China and then ended up in the Philippines. And the reason why this picture is so relevant is because her mom ended up becoming what she called the medicine woman of her town in the Philippines. So I'd like to think that my maternal grandmother actually had a big influence because there was already something in my genes about wanting to care for people. My mom actually became a nurse and then immigrated over to the United States. She wanted to try to have a new life and come to a new place. And I really am still in awe of that bravery that she had of moving to a new country to hopefully give her family a better life, her future family a better life, but then also to see what opportunities she could discover in a new place. And this is her with her 3 other sisters, my aunts in the top right. And I love all of these women so, so much. And it's funny because my mom was the youngest girl. She was considered the runt of the family and they didn't think she was going to do anything. And she did everything she could to prove them wrong. So I thought that that was so neat. And I think that some of my spunkiness comes from her. I wish I could tell you, and by the way, so she came over as a nurse and then she worked as a nurse until she had me and my brother. And then she stayed at home with us and you know, helped take care of us as we were growing up. I wish I had pictures of my father when he was young, but truth be told, I don't know that he has any. He was born in Indonesia, where his parents had fled from China and ended up in Indonesia. He was born there. He had a pretty tough life, as my mom did as well. Both of these are third world countries. And his story is a little bit different. He actually went to medical school in Indonesia. And while he was in medical school, there was a coup. And the government was overthrown, and there became a slaughter of Chinese individuals in Indonesia, and my dad had to flee to his province, and he was quite literally afraid for his life. He was there just practicing as kind of a lab tech and someone in the hospital when a Mennonite missionary met him and realized what potential he had, having graduated from medical school, and said, "You're coming to the United States." So my dad came to the United States. He was, I believe, somewhere between $200 to $400 in debt because of his plane ticket and knew 0 English. And he then worked as hard as he could to fit in, not only fit in, but also succeed and create a better life. And he was so grateful to have a home where he did not fear for his life that he ended up joining the reserves and then served in Desert Storm. So I'm very proud of him for that. He is a physician, he's a radiologist, and he has passed on to me so many wonderful lessons that I'll probably interject as I go along here. And these are my parents actually at a wedding that we were attending, and you'll never see my dad smiling. So this is a rarity. And I'd like to think that I get my personality from my mom. She's very outgoing and talkative. She's never met someone that isn't her best friend. And but then from my dad, I got his diligence and love of science. And so I think it's a good combination to have. Whew, this is a little embarrassing. I mean, this is the fact that we're streaming on YouTube. When I heard that, I thought, man, I got to delete some of these pictures. But this top left is me in 3rd grade. And if you look on the bottom row, I'm 3rd from the left. Yes, I have pink tights and glasses. And my mom put my hair in curlers, little rollers, like those sponge rollers the night before. So this is me when I was growing up. I actually was born in New York. My parents moved to Texas because my mom said, if you don't move me somewhere that's warmer, since I grew up in the Philippines, I'm leaving. So my dad moved us to Texas so that we could be somewhere warmer. And that was a huge culture shock for me. That was when I was 5. And then around Sherman Denison, Texas, I ended up attending the University of Notre Dame. This is not when I was a college student. Because there's none of those pictures that you all need to see. But this is actually me at Notre Dame later with one of my roommates here, Nerea. She is from Spain, or her family's from Spain. And this is me taking my boys to Notre Dame, including my husband. And then this is a picture of me at my quote unquote graduation from internal medicine residency with my parents and my wonderful husband at that point. We met in medical school, dated, and then married just after medical school and just before we started residency. And I really owe so much to these people right here. So I just love showing you guys this picture. My husband now is an orthopedic surgeon. He's a sports orthopedic surgeon who specializes in the shoulder. So just a little bit about that kind of time course. So just if you want to think about what this looks like for you, if you want to become a cardiologist. First, after I graduated from high school, I attended the University of Notre Dame. And following that, I did end up going straight into medical school at UT San Antonio. So UT San Antonio Medical School, it used to be called Health Science Center. I think it's now called something else because names of medical schools change all the time. But I did attend there for medical school for 4 years. I then went into internal medicine residency for 3 years, also at San Antonio. Part of that was because my husband and I needed to match together, of course, at the point we were married. And that is where he matched for his own training as well. So that's why we ended up staying in San Antonio. And then following that, I actually stayed there for cardiology fellowship. At that point, my husband and I knew everybody at University of Texas San Antonio. We had the entire cafeteria in terms of the people that worked there down pat. We knew every single person. And so, and we had our favorites, and they had us as favorites, whether it was me or him, and you ate better that way. Can I just tell you that? And then finally, after I finished fellowship, I came to UT Southwestern as faculty in 2009. Here is me getting my second COVID vaccine, a very, very momentous moment here. And so that's when I started on as faculty as a general cardiologist. I cannot go without saying, and I think some of these questions popped up in the chat, at least when Dr. Nesbitt was talking, and I think it's a really important thing to mention, which is I still have this wonderful family, and it's amazing. So this top left picture is a picture of my first son when he was just born. This is, I think he's 24 hours old here or less. And I had him 4 weeks before I started cardiovascular fellowship at the hospital that I was training. On the top right here, this is a picture of his little brother and him. So this is maybe within a week of Cannon being born. And I had him in my 3rd year of fellowship, April 29th. So his birthday's coming up. And then this bottom left picture is actually as faculty. I became pregnant with our 3rd gorgeous little girl. And these are the boys kissing my belly just before I had her. I think I had her within 24 hours. And then you can see her as a baby here with her 2 big brothers. And then you can see our whole entire family here with her sitting on her, the eldest shoulder. So it's just been a wonderful ride. And I want to stress that somehow we've made it work. We have 2 physician family. We have 3 amazing children. And I'm very, very proud that somehow we make that work. So you may wonder, what do I do as an academic cardiologist? So as I mentioned, I do lots of different things here. So I'm going to dive right in to what a cardiologist does. So again, I'm a clinical cardiologist. I take care of patients. I educate. So I teach medical students. I also teach residents, and I also teach cardiology fellows. So at every stage, I do write. And then, of course, I get to work with Dr. Nesbitt as a leader at UT Southwestern Medical School. One of the biggest questions that seems to come up is people think that I do surgery, and I don't do surgery. There is a difference between a cardiologist and a cardiothoracic surgeon, and I wanted to put this up here because this question does come up so frequently. So as a cardiologist, I manage cardiac issues both as an inpatient and an outpatient. So I do round as an attending. I'll show some pictures of that here in just a second. And I do see patients in clinic. I also do lots of really fun things other than see patients in clinic. I get to read echocardiograms, which I'll show you one shortly in our case, which are basically ultrasounds of the heart. I like to say it's like looking at a baby, like ultrasound of a baby, but we're looking at the heart. So I get to read those as a type of sort of x-ray, moving x-ray. I previously performed angiograms where I would put catheters up to patients' hearts and inject dye and take pictures. I don't do that any longer, but that certainly is an area of cardiology. to give that up as I've become busier as an educator. I treat valve disease non-surgically. So people that have problems with their valves, I'll talk about that more in a little bit as well. Take care of people with rhythm problems, so the electrical part of the heart, like arrhythmias, pacemakers, defibrillators, things like that. And I also get to take care of patients whose hearts are failing. So really there's a very wide range of things that I get to do. What does that journey look like? As I mentioned, college, medical school, residency for 3 years, fellowship for 3 years. And then if you want to do a deeper dive into a certain area of cardiology, you may actually even want to do a specialty fellowship here. Whereas a surgeon, a cardiothoracic surgeon, they're the ones that perform the surgeries involving the heart and the lungs and the chest. And that includes transplants. They also see patients before and after surgery, and they handle surgical complications, and they consult on our cardiac patients whenever we believe they need to go to surgery. And their pathway is a little bit different. So they go down a pathway towards general surgery residency instead of internal medicine, and then a cardiothoracic fellowship. There are also integrated pathways that are very competitive where you don't have to do both of these things like residency and fellowship, which combine those two. So as a medical educator, what does that mean? Well, as I mentioned, I get to work with lots and lots of different people. So medical students up here on the top left, I get to work with residents. This is me, the bottom left. You can see how wonderfully diverse this group of people are that I get to work with. And this is us caring for patients at Parkland Hospital in the bottom left. And then middle left are all the cardiology female fellows that I mentored for several years. And so I really get to not only teach lectures, I get to teach on the wards and in the ICU. I get to coach, guide, and then also celebrate with learners, which is just absolutely wonderful. I also get to be in meetings with students, et cetera, and sometimes Quinn, my little girl, likes to join. So I just thought I'd show that to you. Now, as an author, again, I kind of giggle a little bit when I say this because I never thought that I would consider myself as being one of these people. But one of the wonderful things that has happened to me is I've found just a passion for several things within medicine and within the medical culture. So one, you can see here that I have a big interest in diversity and inclusion. And so I've been able to be very fortunate to publish some papers in that realm. But I'm also very, very interested in gender differences in education. So I've also been able to do some work around the relationship between confidence, gender, and career choice, and then the effects of gender on resident evaluation. So these are just some of the areas that I really am passionate about. And then another big area that I'm passionate about is end-of-life care and defibrillators. If you don't know what defibrillators are, those are the devices that are implanted into patients that shock them if their hearts were to, in a few words, I'll say stop, but really it's going into a bad rhythm. And as patients may approach end of life where they want to have what some might consider a good death, patients may want to turn off these devices. And I'm a huge advocate for having conversations around that to make sure patients can really travel that journey towards death in the way that they want to.
Hey, Melanie,
and then here are some of the articles that I
Melanie, we have a board we have a nonprofit foundation in Texas now, specifically for the physician's orders for life-sustaining treatment, so that people can prepare for the end of their lives, rather than so often as you see and we see in the ER, people approach the end of their lives chaotically. With little preparation, advanced cancer that is clearly very advanced, and yet they want a full code. I mean, really? What you're talking about is such a very important part of our work.
Oh, I love it. I love it. I really I feel very strongly. One of my mentors told me that there are two jobs of a physician: to cure disease and to alleviate suffering. And I often use that when I talk to patients, because I say, if I wish I could cure, but I'm not, I'm not God or whatever you may believe in. And I say, if I can't cure, let me at least do whatever I can to alleviate suffering and walk this journey with you. You're not alone. So I think that that's something very important to keep in the back of your mind for anybody that's thinking about going into medicine. Kevin MD is a blog. So you guys, I am a little bit up to date. So not very much, but a little bit. I've written some pieces for Kevin MD One of them was actually in my car. I typed it out on my phone as an email to myself when I had to talk to a 30-year-old patient about the fact that he was going to die with his mom sitting right there. And it just, it was a tough conversation. And this is one of the ways that I can express myself and put into words some of the biggest emotions that occur as I practice medicine. So that's been a real gift. Leadership is also incredibly important, and I cannot stress this enough. I think as physicians, it does not matter if you are in education, whatever you are doing, you're always going to be a leader in medicine, and I don't take this lightly. I believe truly that I need to act in such a way that is becoming of our profession and being a leader in the community. And so some of the things that I've gotten to do in this role is on the top left, I did a sort of like it's not a lecture, but spending time with students as you're doing a walk. So exercising and also coaching and spending time with them and talking about heart health. This is me at the top middle talking at an ACC conference, American College of Cardiology conference. I think it's important to live and walk the walk. So me getting the vaccine, as I mentioned. This is in the gross anatomy lab with all of our fellows. Not only do I get to teach the fellows, but I get to recruit them to be educators themselves for the next generation, so teaching the medical students. This middle slide in the very middle is me showing, Shauna, by the way, I used you, some of the best and most brilliant and wonderful leaders at UT Southwestern who are women. So I also get to show, the next generation that women do have a spot at the table. This is American Heart Association Heart Walk. This is me with one of my mentees presenting a poster of data that we provided. And then this is me as Dr. Nesbitt was doing a moment of silence online virtually. This is me with several of my colleagues during a basically moment where we had actually quite a long moment of silence for the Black Lives Matter movement. So, and these are all cardiologists or future cardiologists. So I was very proud of that as well. Whew, what does my week look like? This is a snapshot of my schedule, and I'm not going to go through all of this, I promise. But I read EKGs. These are the EKGs that you may see like on TV. I read echoes. I go on a lot of meetings where Quinn sometimes shows up, my little list. I go see patients in clinic. So Wednesdays are my clinic days. Thursdays, I have lots of meetings, but I also make time to go see my patients who are admitted in the hospital because that's important to me, because it's important to them. And then I also either give lectures or attend lectures like internal medicine grand rounds. And then finally, this is my last slide just about this part. There's a lot of questions about the pros and cons of being a cardiologist. I'm going to tell you right now that I put this for pros and cons that may be your pros and cons, but I'll be very frank with you. Any one of these things could switch to the other side, depending on who you are and how you regard it. So I love caring for people. I love taking care of critical care patients, so that's a positive for me. That was very important to me, that I took care of patients who were, very sick. It really allows for me to become close to the patients very quickly, and that is a meaningful thing. I really love doing procedures, so I really wanted to go into an area that I could do procedures and do things with my hands, and I can with cardiology. There's a wide variety. I can act sort of like a radiologist reading echocardiograms, but I also get to see patients in clinic, but I also get to see patients in the ICU. So there's a wide variety, which is a huge positive. And the relationships are unlike any other. Some of the negatives that some might consider, but again, any of these could be considered on the other side, depending on what your viewpoint is. It is a long training in terms of, how much training you have to go through. This is a busy life. It's a very busy life. I wouldn't trade it for the world. I hope for all of you that you find the area and find the thing that you can do so that you never work a day in your life. You love it so much that you never work a day in your life. But for me, I do get calls. I get texts almost every day from friends, from family, from just acquaintances asking me cardiac questions. And they're never, oh, this could wait for about a month. Cardiac questions tend to be pretty darn in the moment you need to answer it. So you're quite busy with that, but at the same time, I really enjoy that. You definitely have higher risk patients, so you do have situations where you lose patients. But I say that with a little bit of caution, because remember that there's 100% mortality in medicine. So when we lose patients, it doesn't necessarily mean that we as physicians have failed, or we as healthcare providers have failed. There is a time for every single person to leave this life. So I say lose patients, but I wanted to put that asterisk of discussion to say we don't lose them. Everyone, comes to the end at some point. And you do manage end of life and death. And again, I don't actually think that's a negative. For me, that may actually be a positive, because I think that's one of the greatest privileges of being in medicine, being a doctor, and being a cardiologist. And so with that, I probably talked even longer than I should have, but I will stop there, because I think that is my last slide before we get into the case. Yes, that's right. So I'm going to stop sharing my slides and hand it.
Melanie, let me ask you to maybe lean into the microphone just a little bit. We're getting it's breaking up, kind of choppy sometimes. So sorry to bother you, but okay, all good. Thanks so much.
Okay, so can you all see that?
Yes, ma'am.
Okay, so Mel and I thought we would kind of walk through some of the key questions to answer. And as we kind of walk through, maybe we can also answer questions, Dr. Fowler, that, sort of fits these questions, because I thought these are questions that, as I have been looking at the chat box, a lot of the questions that you all have been asking are the ones that we're going to kind of walk through. So first, what are your key questions to answer? Someone did ask, when did you decide you wanted to be an academic physician, and how did you make that decision? So I think the very first question to ask yourself about anything is, what is my passion? Is what do I like doing the most? And the reason you want to ask that question is because whatever it is, understand that you will do this all the time, literally all the time. On your off days, you will do it. On your work days, you will do it. In the last week, I worked from home, sometimes starting at 7:30 and ending at 7:30 or 8 o'clock at night, and then still have 4 or 5 phone calls from friends and family members who call and ask a question that is still related to what my day job entails. And so, and I'm not tired. I mean, I'm not tired of doing that. And it's because that is my passion, and I can do it all day, any day, all the time. And that really makes a difference as far as your ability to sustain your interests. What are you good at? Are you really good at taking care of people? Are you patient? Are you a listener? Are you, does blood really frighten you? All of those things are really important in any career in medicine. In cardiology, there's certainly a breadth of what you can do. And Mel does procedures. Well, she used to. I don't do procedures. Probably the most invasive thing I do is have people wear a blood pressure monitor, and I read the blood pressure monitor. But you have the width of doing all of those things, and it's a matter of which ones you'd like to do. And I think you should always ask yourself the question, where would I like to be in 20 years? And I know for most of you, probably 20 years seems like it's a lifetime away, but it goes pretty fast. And starting to plant seeds makes a real difference as far as where you land if you begin that process very early. Mel, you have any feedback?
Yeah, no, thank you. Can you guys hear me okay?
Not quite. It's you're a little distant. That's
a little distant.
There you go. That's
okay.
better. Yep.
Is that better? Is that better? Okay, great. So no, I love everything you said, Shauna, and I want to tie this in, and hopefully I'm not jumping ahead, but I want to tie what you're saying into some of the questions I saw in the chat too. There was one about being a mom and how do you balance it all and how do you do all these things. And I think I just want to give you guys my perspective, and it's just one perspective, so take it, for what it is. What I like to share with people that ask me this question is I say, I actually feel that I'm super fortunate because I get to take care of people who are dying and who have heart problems. And then I get to spend time with my kids and my husband. And I really concentrate my time on those two things. And when it comes to, it actually puts into perspective a lot of things that don't matter as much to me. So for instance, I will tell you that it's a great excuse. So when people are asking me to do things, or when they want me to participate in a conversation that maybe I'm not, I don't find it as important as those two things. Like, do I care if my kid uses hand sanitizer or washes his hands before lunch? And there's like a big debate about it at the school. You know, when they hear that I'm a physician and I'm a cardiologist, it's a really good excuse to say, you know, that's not something I want to or need to participate in. I would love to help in whatever way I can for my kid, but I get to really focus my time on really FaceTime with my kids and then FaceTime with my patients as well. So for me, I think it kind of puts into clarity where I want to spend my time. And then I also have gotten such wonderful advice from people about, you know, where can you get help, you know, once you are out in practice, so that you can spend a lot of FaceTime with your kids and your family, and then also spend FaceTime with your learners and your patients as well. So it takes a village too. So make sure you have a partner that's supportive, and then also make sure you surround yourself with people that support your mission and what you're doing. I will tell you this morning, we have a nanny, and I shared with her an entire story about a patient who was dying, who got a new heart. And, you know, she was in tears. And I said, thank you for what you do that helps us, because it allows me to do what I get to do and spend time with my kids. So make sure that you, use that village around you.
So steps to get there is, you know, programs like this one are good sources of information, is giving yourself a broad background, being able to understand a breadth of fields, reading some books. The internet is helpful, talking to teachers, talking to people who actually are in the field, summer programs, volunteering. The value of volunteering is incredible, because part of what we do is advocate. It is the heart of what we do. And if you find that you love advocating for other people, this is a field that will really fulfill you all the time. And a good place to practice that is to do things that have no real direct return to yourself, because that is how you learn if this feels good for you. And sometimes people are doing things for other reasons, but you should do it because it is genuinely a part of who you are and how you feel that you can contribute to the world. And I think medicine is full of people who have that sort of desire, regardless of what field you choose. In terms of the simple steps, obviously, grades matter. Your MCAT score matters for getting into medical school. But more importantly, it is developing that who you are and your why statement, so that you have the ability to really discuss and present that in interviews and in personal statements that you write about yourself. These are all of the just perfunctory steps that you need to know to get into medicine. But along the way, it is your experience and how you expose yourself and how you interweave your personal journey with the learnings that you will gather along the way that help to build your ability to make a good decision for yourself.
Shauna, you said that in high school, you already knew you wanted to be a doctor. How'd you know that?
I knew about 7th or 8th grade, I knew that I really liked science, and I knew that I really liked helping people. Science, and for me at that age, I didn't really know of a career that I could actually get into other than being a physician, that I could use those two skills. And perhaps that's just because the exposure was so limited. But as I went forward, exposing myself, I came to realize that this is exactly what I want to do. This is exactly where I belong. And I think that is an important part of it. sometimes when you're young, we choose according to what we know, but the key is to give yourself the exposure to be able to really understand, is this what I want, before you jump in.
So do you have to be an absolute genius to be able to go to medical school and become a PA?
You do not need to be a genius. I am not a genius.
Agreed.
I will say this, I am a hard worker, as that I have learned to work hard for everything that I've gotten. And I don't take any, I mean, I think that's what I do, and I'm good at that. And I think that even if I were a genius, that this requires me to work hard, that the hard work part of it is what really matters.
I like to say that if you'll give me somebody who has a reasonable intelligence, a reasonable aptitude, who has a strong work ethic, and who's just a nice person who likes people, they'll be a great medical provider, because that's what it takes. You've got to have all those.
Absolutely. Absolutely.
You know, we have very high expectations of our medical students, of our PA students, of our nursing students. And that's one of the aspects that our young learners kind of forget about it. That it's not really that I want you to be a genius. It's just when it comes to taking care of patients, it's like really a craft. It's an art. There's a lot to learn, and we have high expectations for you. And we're going to be looking for folks who welcome that challenge, who have the aptitude to undergo those rigors and excel, because ultimately you guys are going to be taking care of my generation. And when I'm a patient, I really want the cream of the crop, compassionate, empathetic people who did go through school and got good at it. So just always remember that.
You know,
I couldn't agree more with that.
Yeah,
I couldn't agree with that.
Yeah, one other little point. I think that to become an empathetic, humanistic physician, you have to kind of eliminate the first person singular pronoun and rather use the first person plural, which is we,
Yes.
and only use the second person plural, you, to say, I am so proud of you.
Yes.
Because you get so much by doing that.
Yes.
It's true. I think personally, this is just my opinion, is that the people that are most successful, but not, and when I mean successful, I don't mean my money. I mean successful in terms of taking the best care of patients and then loving their life. They go into it for the care of people. They go into it for, what they get out of it by taking care of others. And I would just want to second, when people say genius, to go into medicine, sometimes people think of that as taking tests. And the truth of the matter is taking tests is just one small aspect. Obviously, you need to be able to do that in order to, traverse through the education, but it's also that EQ, that emotional intelligence, your resilience, your go-get-em attitude, that hard work ethic. So I just want to reiterate that. So spot on.
So what are the key things we have to do here?
The key things is to develop some good study habits, is to really focus yourselves. If you're an athlete, you would practice every day. And it's the same, is that if you're going to be a physician, you need to practice your study habits. You need to develop them like you develop any other muscle. You need to volunteer and help people learn about yourself and how does that feel for you, because sometimes it doesn't fit for you and it's okay, but you definitely need to do that because you're learning about people as you do that. Expose yourself to medicine. Do you like the life that Mel and I and Dr. Fowler and Dr. Salazar live? We have, very distinct ways of existing and how we integrate our personal lives into our work lives, and it needs to fit for you. Is to get involved in summer programs like this one that help you to gain a little exposure to medicine, to people who are in the field doing it every day, and ask them the right questions. Don't be ashamed to ask any question. No question is a dumb question. All are important because you have them. And then establish some relationships with people who have the knowledge that you need, that can help you along the way. Professors, supervisors, maybe your own doctor, people who might write great letters for you, They need to know you personally, because that's what you want them to talk about, not just your academic performance, because we can all read transcripts, but we really want to know about your character. So people who know you that way are really good. And then finally is the process will always involve some aspect of interviewing, whether it be remote or in person. But this is all about how do you communicate yourself, about who you are and what you want, and you need to be able to do that clearly. So practicing it is a good thing. I used to do that with a tape recorder. So no one has tape recorders anymore. You can do that with your phone. And so practicing what your message would be and then listen to it and how you communicate it can help you to be really well prepared.
Can I just give major props also to Dr. Fowler and Dr. Salazar, who are answering these chat questions in like record timing, by the way.
You guys are good. We have cases and we're at 8 o'clock, but I'm happy to do our cases if it's okay.
Shauna, you can talk all night long. You've got 400 rabid kids sitting on the edge of their chairs, just loving every word. We've got about 30 questions in chat, but this is absolutely tremendous. And you just take it away. Do whatever you want.
Well, let's do our cases, Mel. What do you think?
Yeah, no, let's go for it. I love it. Some of these questions are just amazing. So I'm just reading through the chat. So yeah, please go ahead.
Okay, so we've got two typical cases of patients that we take care of, and the idea is for you to get a sense for what we do when we have a patient in front of us. So my case is a 56-year-old African-American male who presents to the clinic with headache and dizziness. And it began two months ago, but it's worsened over the last 2 weeks. He's a bus driver. He has arthritis in his knees, and he's in pain daily. He takes Motrin, which is ibuprofen. That's a nonsteroidal medicine over the counter. He smokes a pack of cigarettes a day, and he walks 2 miles. He lives with his family. He's active with his kids. He's not had any surgeries or other illnesses in the past. His father died, notably at age 50, of sudden cardiac death. So this is a typical story that someone would present to you either in the clinic, or they could even be coming to the emergency room with these complaints, basically because it's a complaint of headache and dizziness that seems to be getting worse. So on physical exam, first, his blood pressure is 179 over 100. Now that's high. Blood pressure should be below 120 over 80. That's seated, and standing. Generally, blood pressure should drop when you stand up, but his goes up a bit. He remembers that his blood pressure a year ago on a work physical was 150 over 90. Heart rate is 72, which is the normal heart rate. He's got a normal temperature at 98. His respiratory rate is 12 per minute, and that's normal. His weight is 220 pounds, and he's 5'11". On the rest of his exam, HENT, that is referring to the head, eyes, ears, nose, and throat. On his eyes, he's got what we call grade 2 retinopathy. What that means is that in the back of his eyes, if I use an ophthalmoscope to look in the retina of his eyes, he's got some blood vessels that look like they've been damaged, probably by his blood pressure. On his neck exam, it's normal. His lungs are clear. His heart exam is normal, except that when I feel on the front of his chest, for where do I feel the point where the heart is beating closest to the chest wall, that's what we call the apical impulse. It's a little bit displaced toward his arm, which means the heart is bigger than it's supposed to be. On his abdomen, it's not normal, and on his legs and feet, he's got normal pulses, but his knees are a little bit tender when he tries to bend them in front of me. So what are the important pieces here? The important things about his story is that his symptoms. He's got a headache, he's dizzy. It started 2 months ago, but now it's worse. He's got knee pain, and he takes over-the-counter medicines. He's a smoker, and he has this family history of early heart disease and death in his father. That's important. On his exam, his blood pressure is elevated. and there, it does not drop when he stands up. His eye exam suggests that his blood pressure has been a problem for a while and it's already damaging his eyes. His heart exam is a little abnormal and probably from the blood pressure. His knees are painful, but he doesn't have any swelling in his knees. If we move on and look at his labs, so creatinine is a blood test that we commonly do to look for kidney function. And a normal creatinine is below 1.0. And so at 1.4, we can say that he has what we call chronic kidney disease, or a little bit of kidney damage and decline in function. His potassium level is 3.8, and that's normal. His blood sugar is 122. That's a little borderline, but if he was not fasting, then it might be okay. On his urine test, he's got a little protein, which he should not have, so that's abnormal. His cholesterol is above 200, it's 234, that's high. His HDL, that's the good cholesterol, should be above 40, and his is low, so that's a bad thing. And his triglycerides are at 145, which is a normal range. Just to give you reference, when we think about blood pressure, this is the most recent blood pressure categories from the American Heart Association, the ACC, and the Association of Nephrology and ABC, all of the organizations basically. Normal blood pressure should be less than 120/80 in the green, but elevated is between 120 to 129/80. And then high blood pressure is anything above 130/80. Either or, and then what we call stage 2 is above 140/90, and crisis is when it's over 180 or over 120 on the bottom. So these are important things about his case. The damage that you can have from high blood pressure, I mentioned that his heart feels like it's big, and this is what it would look like. So on the left side, you see a normal heart kind of sliced down the middle, with the left side in the red and the right side in the blue. But if you go to the right side of this picture and look at where it says left ventricular hypertrophy, that's a common problem associated with high blood pressure. And most notably, you see the pink lining around the left side of his heart is much thicker here than it was with the normal size heart, which means that this part of the heart is pumping really hard against high pressure to get the blood to go through that little valve out to the rest of the body in what's called the aorta. So the damage that blood pressure can cause across the whole body, one is, as I showed you, it can cause the heart to be big and thick. It can also contribute to you having a heart attack. This is a blood clot in this blood vessel. You can have problems with blood vessels. This is a blood vessel in the brain, and you can see there's some clot developing here. And if that clogs up this opening, what should be a wide opening space here, you get a stroke, which is dead tissue in the brain. In the kidneys, because the blood vessels, again, the pressure's too high, it can damage the kidneys. So the kidneys don't work so well anymore. In the eyes, you get these little red spots. These are normal blood vessels here, but what you see is some swelling, these cotton wool spots, and you see blood vessels that have been broken. Every place you see these little red little spots, those are all because of high blood pressure. And then finally, you can develop what's called heart failure, is that now the heart has so much damage, it's weak, it's not able to pump against the high pressure, and it starts to fail. So we call that heart failure. These are all the end stages of having high blood pressure. So when we evaluate patients like this one, we look at the risk factors that he's carrying. So first is, how old is he? And he is 56. His family history, the smoking, his lifestyle, his overweight, and his body mass is 30. So he is obese. His blood pressure, his cholesterol profile, his blood sugar, and the HDL. Remember, I told you it was 35. So that's actually what we call a negative risk factors. Normal would be above 40, and his being low makes him high risk. So we put that all together and then we calculate it. What is his cardiovascular risk? So we use something called the cardiovascular risk calculator. And let's see if we can you see that risk calculator?
We see the word riskcalculator.com.
Okay, one second. Let me share one more time and hopefully it'll come up for you. Can you see that now?
Oh, there it is.
Okay, so let's put in his risk factors. So he's 56, he's male, he's African American, his cholesterol level is
his HDL was low.
His HDL was 35. His total cholesterol was 234. His blood pressure was 170 and 100. And he's not taking medicine, he's not diabetic, but he is a smoker. So if we use those in the risk calculator, and that has been accumulated across population studies like the Framingham Heart Study and the Dallas Heart Study, we get a 10-year risk of heart disease. In his case, he's at 21.7%. We consider that to be quite high. And so he's high risk for having a heart attack in 10 years. And why is that important? It's important because it helps us to decide how aggressively we need to choose his therapy. So we now go back and start to think about, okay, what are we going to do for his blood pressure? First is to talk to him about smoking, talk to him about his diet, talk to him about his weight and losing some weight. We start him on blood pressure medicine immediately. We start him on some statin therapy, drugs like Lipitor, and I'm sure you've seen them on television being advertised. Actually developed at UT Southwestern. We start him on a low dose of aspirin, talk to him about exercising, and then stop the extra use of drugs like Motrin because they actually damage the kidney and can also increase blood pressure pretty significantly. And if we can get him to do all those things, there's a good chance that we would get him under good blood pressure control and reduce some of that risk and hopefully save him from all of those terrible things that I showed you that happened to his body along the way. That's the kind of thing that I do every day. And we work on blood pressure with patients. We work on their lifestyle modification. It takes some time, but along the way, I hear some incredible stories from people, and it helps me to understand their stories so that I can give them clear direction about what medicine really fits them and what kind of lifestyle changes they're really capable of making.
You know, the reduction control of the body's lipids, the fats, the cholesterol was developed by, as you well know, Melanie and Shauna, two Nobel laureates at Southwestern. And I've gotten to know Mike Brown pretty well, who's a wonderful person. And we talked about it a great deal. And for the world to say several years ago that the most important thing that year for medicine in the world was something that would control cholesterol, that says a great deal about how important this is.
Yes, absolutely.
Dr. Nisbet, hypertension is just phenomenal to me. And, you know, much like your family, my family has significant risk factors. I feel our generation is a lot more well-versed kind of in diet and what we have to do, but a good dietary kind of habit arsenal is not possible for every single patient. And I've learned a lot about things like food deserts, for example. So what is your approach when you're discussing the role of diet with patients who may not have the ability to purchase healthy foods like you and I might?
Very important. And so that is one of the reasons that one of the key things I like to do with medical students and residents is to really teach them to ask people about their life, is rather than treating people like a case, you treat people like this is a human being who has a life. What is it that you do? What do you like? Who prepares your meals? Where do you buy your meals? What are your favorite foods? Those are all important questions because you are asking them to change their life, not just change one day, but the rest of their life. And so I talk to them about, okay, here are things that are practical for you. If we talk about maybe one thing, are you buying canned goods or are you buying fresh or frozen fruits and vegetables? Can you buy them? Are they accessible to you? And sometimes I hear, I would love to be able to do that, doc, but I don't have a store close to me that sells fresh fruits and vegetables. I can only get cans. What can I do? That helps me because then I tell them, okay, what I want you to do is pour the water off, rinse your vegetables before you cook them. Don't drink any of the water that they're in the can in. It's not perfect, but it's certainly better than if you just use that. Other things I talk to them about is, how much alcohol they're drinking. And sometimes people don't realize, that they are drinking the equivalent of 2 beverages in one can, because now we sell people really large quantities of things and call it a single serving when it's not. I talk to them about that. And what are your favorite foods? Where do you go for fast food? I'm not a fan of fast food, but I need to know, where is your fast food place? And then what are you picking off the menu? And then I help them to rework, what are they going to pick and what are they not going to pick from the menu? So I think we need to, there's this whole concept of boutique medicine, and we all think of that as being expensive. Rich people can access boutique medicine. I think every patient is a boutique patient because every patient deserves my attention completely. And I should be designing something that is boutique for them so that they walk away with a prescription that is uniquely for them.
Gil and I work in the busiest emergency department in the United States, which is Parkland ER. And I have to say, pushing 70 years old and going on 44 years of clinical practice, the most special thing in my life, and it's a very social thing for me because part of my social life is with my patients, is to kind of get into them a little bit. So where do you live? You got family at home? Tell me about yourself. These sorts of things, because people are part and parcel of where they live, who they're surrounded by, and so forth. A subset of that is, what support group do they have? For example, we're getting a lot of questions in chat about obesity, Shauna and Melanie. And so you say, well, how do you help them? Well, they've got to have a support group if they're going to lose weight.
Right. They've got to have a support group. And I think we help people when we help them to set goals that are manageable. No one likes to fail. Everyone likes to have some success, which is motivating for you to do the next thing. And so in terms of weight loss, I talk to people as, I don't want you to go to the mirror and start criticizing whether you fit into the best outfit. I want you to think about, what is a feasible goal for me eventually, but for right now, where do I need to go to have my health improve? So it can be 10 pounds. And how long will it take you to get to 10 pounds? I don't want it in a week, because all you're going to do is sweat that out. I want you to lose 10 pounds in about maybe 2 months, because actually the rate at which you lose weight is going to go fairly slow. And I think setting a realistic goal is one that you can maintain for a lifetime, not just for a fad diet that gets you to, a special event, because this is lifestyle changes. So, and the other part of it is body habitus does matter, is where you have the largest part of your weight. If you carry a lot of your weight around the middle section, it's more unhealthy than if you carry a lot of your weight around your hips and legs. Both of which are not ideal, but there is a clear difference in terms of the cardiovascular effects that it has.
So the high protein, low carb diets and the related diet, the keto diet, are you a fan of those? Or
I'm not. I'm not, for a couple reasons. One is I think that they promote rapid weight loss, but I think the maintenance of them is very hard for people to do. It's not cheap either to do it right. So I really think that helping people to develop a balanced diet is a much more sustainable and healthy way to live. I think that there's some questionable effects that those diets have on cardiovascular health. There have been some studies that have shown increased risk of MI and the negative effects that I just don't simply agree with.
So Shauna, this terrible epidemic that we've had, last time I saw something like this was, in the early 1980s. I've been in practice already for a few years when typically males started showing up in the emergency department, very short of breath, covered with sores, and they would come in and die. We didn't know what it was, but then Fauci, the same Fauci, named it HIV in about 1985. What have you seen, now coming to the present now, what have you seen about the isolation and the depression and so forth, and its effect on people and their blood pressure, their weight, and so forth in the last year?
I am seeing people come in and they've gained weight because they're at home and they can't exercise and what their normal routine would be. Even people like me who would normally be walking from building to building and up and down stairs, and I'm sitting in a chair all day for a lot of days. You gain weight because you're not physically moving. Energy in, energy out is what determines your weight gain. So I'm seeing a lot of people gaining weight just sort of in a gradual manner and not even conscious of it. I'm seeing a lot of people whose blood pressures were under control and all of a sudden it's starting to go up, partially because of weight, but the other part of it is that there is a significant emotional stress that we're all suffering from that is in part due to isolation, because isolation is really goes against human nature. We are social beings by the way we are designed to live, and being defined to a small corner is not the way we live all the time. And so it matters that this is extended for so long. There's no direct relationship between the virus itself and blood pressure. There was some question of that early on about the angiotensin receptor blockers, but more recently we've found that that's not necessarily true. It's more that people who have cardiovascular disease already are likely to be on those drugs. So it looks like that might be an issue, but blood pressure itself has been poorer control for this reason.
Plus there's another factor, so many millions are working from home. I mean, this for me right now is my 13th hour on Zoom today, sitting on my couch here in my house. And I know y'all are doing the same thing.
Yeah.
And so one of the effects of COVID then is we've become sedentary. Yes. Not all of us, of course, but, and so that's been an increasing stress, just not moving from, getting up, moving around place to place and so
on. Yeah, that's absolutely true. I think we both endure that right now.
This is terrific stuff. Melanie, you had something?
No. I just had to agree. I'm agreeing with everything that Shauna said. I'm seeing so many fabulous questions in the chat. And I don't know if, Shauna's done such a wonderful job with her case. And we've had some questions already. If you want me to move on to my case, and then we can reserve the rest of the time remaining for any just other questions, either about cardiology, about hypertension, or even about the career.
Please move on. I saw a cardiogram there. I can't wait to see what's on.
Okay.
She's got some other really cool things to show you. So you definitely want to see her case.
I love it. I love it. I mean, I love talking about diet and exercise and all that good stuff. So I could talk about this forever. So I'm going to try not to. Okay. So I'm going to go ahead and jump into my case really quick here. And I cannot see the chat when I show my slides. So forgive me if I'm not answering some of the questions in the chat. So I call this the attack of the heart. So this is a 65-year-old man who presents with chest pain. And he has a long history of high blood pressure, HTN, hypertension, and smoking cigarettes. And I'm just going to go ahead and give you the punchline, because we're going to take a really big 30,000-foot view of one of the major areas of cardiology that I get to practice and take care of my patients in this arena, which is coronary disease. So the EKG. So what the EKG is that I'm going to talk a little bit more about the heart in a second, but the heart is so fascinating. There's a whole electrical system of the heart that transmits electrical impulses that can be measured by those electrodes that you see on people's skin, or maybe you've experienced them yourself. And so when those electrodes are on your skin, it picks up that electricity and can transmit into what we call an EKG, or electrocardiogram. And what I hope you can see, and I'm not going to go into the details of each electrocardiogram, but on the left is a normal electrocardiogram. And on the right, if you guys can see these really kind of tall looking, I don't know if you can see my cursor or not, but there's these tall looking, what we like to call tombstones on many of the leads that looks quite different from the one EKG on the left. And those kind of changes indicate a myocardial infarction or a heart attack. Those are interchangeable kind of terms. MI from myocardial infarction. So he's admitted to the hospital, he's given aspirin, and just standard myocardial infarction treatment in addition to that aspirin. So let's talk a little bit about the heart. And I'm sorry I get a little excited here, but this is why I love what I do. The heart's really fascinating. The way I like to describe it is it's like a house. And the reason why I say that is because even though it is one organ of your body, it really has 4 rooms, just like a house would. It has the upstairs and the downstairs. The upstairs is the atria, and the downstairs are the ventricles. In addition to having rooms like a house, it also has what we like to call the plumbing. So the plumbing are the arteries and the veins. So the arteries are also called coronaries. So that's why you hear the term coronary artery disease. Maybe you might feel that one of the most confusing things about medicine and cardiology is that we have so many different terms that are interchangeable. So some people use heart disease as one term and coronary artery disease as another term, and almost interchangeable. But what I want you to remember here is that coronaries are the arteries of the heart, and there are also coronary veins, but coronary arteries are the ones that bring oxygenated blood to the muscle so that the muscle can function. And then, as I mentioned, just like a house, there is a conduction system or an electrical system. And so there are these electrical cells that are just remarkable in the heart that literally have programmed within them the ability to create its own electrical impulse that tells the heart when to beat. It's really phenomenal, and I could talk all day about that, but I won't because I'll bore you to tears. But it's really a neat kind of thing. And then finally, again, like a house, there are doors to this house, and we call them valves or heart valves. And what these heart valves are they are one-way doors that make sure that the blood of the heart goes in one direction continuously. Because, right, the blood flow in your body is always going in one circular pathway. It's coming up to the heart to one side, going to the lungs and getting oxygen, going to the other side of the heart and getting pumped to the rest of your body where it gets used up. That blood with oxygen gets used up, and then it circulates all the way back and does it all over again. And if you can imagine that it needs to go in the circular fashion, that if it starts to go backwards, and if it doesn't have one-way doors, but rather swinging doors, two-way doors, that can be a problem, because those swinging doors can allow blood flow to go backwards. And when blood flow goes backwards, it causes problems such as blood in the lungs that causes shortness of breath. So this is the way that I like to explain it to patients and to lots of people, lots of learners, because it's just a very simplified way of thinking about the heart. So let's talk about coronary artery disease really quickly, because this is what I was talking about when I talk about myocardial infarction, or the traditional myocardial infarction or heart attack. So those arteries that I talked about, which is the plumbing that brings oxygenated blood to the muscle. So this is confusing. In medical school, I remember actually there are lots of medical students, and I know many, and it's totally understandable, that thought, oh, the heart gets its blood flow from just the blood it pumps. But actually, the blood that's inside those rooms is not actually how the muscle receives that blood and uses it. It gets the blood to the muscle through these plumbing systems, or the arteries and the veins, and specifically the oxygenated blood to the through the coronary arteries. Now, just like plumbing, okay, the way I explain it to patients is when you have a brand new house, or the best plumbing you could ever have is when you have a brand new house. If you have a brand new house, that plumbing is gorgeous, right? Those pipes have not even been touched before. There's nothing in them. However, the minute you move into a house, and you start using the plumbing, then things start to build up. And the same is true for the heart plumbing as well. So I like to allude it to, so once we start having Big Macs and Whoppers, Sean, I'm looking at you with that Burger King, my friend. Don't get me wrong, Whoppers are delicious, but when we start eating Big Macs and Whoppers, and when we start eating chicken fried steak and start eating some really delicious things like that, that's when we start getting this buildup in our plumbing. And actually Dr. Nesbitt talked about this already a little bit, and we call it plaque or atherosclerosis. And those blockages can prevent the blood flow from flowing through those plumbing the way it should and getting to that muscle. So what are some of the things that contribute? So this is another reason why I love being partners with Dr. Nesbitt, is that we tend to complement each other quite a bit and well. And so I'm going to kind of reiterate some of the things that she was talking about. These are the risk factors for developing coronary artery disease. And on the left of this table, you'll see that these are the modifiable ones. These are the ones that you can actually do something about, versus the right, which is non-modifiable. You can't pick your parents, I'm sorry guys, in terms of your genetic profiles. But what you can do though is you can look at things like hypertension, like Dr. Nesbitt was talking about. You can also work to control your cholesterol. You can stop using tobacco products. And this includes not just smoking, but also dipping and using tobacco products in whatever ways, cigars, etc. Diabetes is a major risk factor for coronary artery disease. Physical inactivity, we were just talking about that because I think that's affecting all of us right now, especially those of us that are in front of Zoom, multiple hours a day. And then a diet high in carbohydrate and fat. So that gets to that question, Dr. Fowler, that you were asking about the high protein diets and low carbohydrates. Sometimes if you get on those high protein diets, if it's a high fat diet, that's also going to be quite dangerous for you as well, because that high fat diet can lead to atherosclerosis as well. And then non-modifiable age. As we get older, I like to compare ourselves to like cars. As we get older, our car parts, they just get worn down, and our plumbing gets clogged up a little bit. So age over time leads to a higher incidence of atherosclerosis. Men do have a higher incidence at a younger age than women, but let it be very well known that the #1 killer of women is heart disease. It is not, I know that that may be shocking to some, but many might think it's breast cancer, but it actually is heart disease. And then of course that family or personal history of coronary heart disease as well. So this is some beautiful pictures. So what we do, and what I used to do is I would be able to pass hollow plastic tubes that are sterile up through the groin or through the wrist of a patient in one of their arteries and pass it all the way up to the heart arteries. And then once those hollow plastic tubes rest in the heart arteries, you can inject them with dye and you can actually see where a blockage is. Now, if you can imagine your plumbing being nice and open like this picture all the way in the right, what a heart attack typically consists of is an artery where a blockage, so one of the little buildup of plaque actually ruptures and then causes a complete blockage of that vessel. And if you can appreciate on the far left that there's absolutely no flow here, then what our buddies can do, Dr. Nesbitt and I, our colleagues, they can actually pass a wire, almost like a railway system down that artery, and then put a stent over it. What is a stent? A stent is actually, the way I like to compare it to is it's about the size of that spring in size pens. I know all of you guys have opened up a pen before, right? You know that little tiny spring in there? I know you know what I'm talking about. It's about that size. They actually can wire a stent mounted on a balloon over this wire or railway system, and then inflate the balloon, deploy that stent into the artery and open up that blockage so that you can get nice blood flow again, like you see here all the way to the right. It is pretty incredible. One of the things that I love about cardiology is that, I really like quick outcomes, or like immediate outcomes, I should say, immediate outcomes. And so it's so rewarding to see a patient who's coming in, could be dying of a heart attack, and really be able to treat them in a fashion like this and make them feel better in a very short period of time. So that is the first part of the case, but I am not done yet because there's more to cardiology than this, and I wanted to highlight a few other things. On the third hospital day, this patient's still in the hospital. Now that sometimes is not the case. We actually can get patients in and out pretty quickly, even with heart attacks, but he was still quite sick. So on the third hospital day, he suddenly gets short of breath. Here's a chest x-ray, and this fluffiness or these kind of markings and where the lungs should be, really show that there's kind of this fluid going throughout the lungs. And he's very short of breath. His blood pressure is low, so he's hypotensive, not hypertensive, and he's coughing with a lot of sputum. So he's coughing up some frothy material from his mouth. He's very uncomfortable, and he's sitting upright when you see him. And now when you look at his EKG, his heart rate is much faster, but it looks about the same as it did before, maybe a little bit better since we restored blood flow. Now, this is a different depiction of the heart that may not make sense, but imagine you are looking down your head and you look down at your chest. This is what you would see, but flipped. So I'm not going to try to orient you too much in terms of that, but what I will say is L is left, R is right. And then remember how I said there's upstairs and downstairs? I flipped this on you guys. Sorry to make this a little complicated, but the atria are at the bottom and the ventricles are at the top. But this is how we read echoes. And the reason I put this in this fashion is because this is the picture that you're about to see as I show you an echocardiogram. Now, this area right here is the mitral valve. Remember, I mentioned that the valves are the one-way doors of the heart, and they make sure that the blood is flowing in one direction. So blood should flow from the left atrium to the left ventricle and then out to the rest of the body. And it should shut and not allow blood from the left ventricle back to the left atrium. Does that make sense to everyone, I hope? So again, blood flow should be coming from the left atrium or the upstairs to go downstairs. It should flow just like blood flow should flow from upstairs to downstairs, okay? And what I hope you can see in this next slide is that when we got an echocardiogram on this patient, and I hope this plays, everybody cross their fingers. It played this morning when I tried it, but it may or may not load. We'll see. But what I want you guys to hopefully see here, and if it doesn't load, then that's unfortunate, but it is what it is. So what I hope you see is left atrium, this is left ventricle, and then this is his mitral valve right here. Can y'all see my cursor?
Yes, ma'am.
Okay, great. So this is the mitral valve right here. And the mitral valve is actually, it was an oversimplified picture that I just showed you, but it's supported by muscles and other structures in the heart that are supplied by blood. And if you have a heart attack and you damage that muscle, what can happen is that mitral valve no longer acts as a one-way valve, but then it becomes impaired. And instead of the blood flow going from the left atrium to the left ventricle, now it's like basically a revolving door. It's going out into the left ventricle, then back towards the left atrium, then out towards the left ventricle and back to left atrium. And the bad thing about this is once it enters the left atrium, it can actually flow backwards into the lungs. And so that's what causes that pulmonary edema or fluid in the lungs and the patient being so short of breath.
Melanie, I have to say, you have a vocabulary about the way you put things, like the door swinging and so forth, that is absolutely charming and so easy to understand.
Yeah. Well, I love that. I'm a simple person, my friend. And that's one of the reasons I love teaching, is because I really love trying to make it as simple as possible, and also so that everyone can understand. And one of the greatest joys of medicine is actually teaching your patients so that they can feel ownership of their own disease and their own bodies, and they can really contribute to their own health.
Speaking of that, if I might,
yeah,
Dr. Nesbitt put, there was a question on there. What am I good at? That was one of the questions.
Oh yeah.
I'm going to brag on the both of you, because I am jealous of something that you all do extremely well. And I wish I was a 10th as good as you are. Both of you are some of the greatest communicators that I know. Not just administratively, educationally, but when I've taken care of patients with you, your explanation, your collegiality, I mean, it's a thing of beauty. So if you ever want to emulate somebody in terms of communication, collegiality, professionalism, you got to be like Dr. Nesbitt and Dr. Solistio, by the way. And I really mean that.
You are so kind, Dr. Salazar.
Thank you.
We will pay you later. Okay. But I really do thank you. That's such a high compliment, though. Thank you so much. That means
Melanie,
a lot.
Melanie, Dr. Salazar prefers high-fat food like sausage and such things.
Yes, only on Friday nights.
I pay you. That's called job security, my friend. That's called job security.
Yeah.
Oh, look, of course, now it plays,
Oh,
guys.
look, there it goes.
You know, it just needed a little love from Dr. Fowler and Dr. Salazar. As soon as it heard y'all talking, then it started going. So there should not be any material coming back into the left atrium here. And can you guys appreciate that there is actually something that's coming back here into the left atrium? And what that is that the part of the valve that was attached out here has now broken off because it didn't get enough blood flow when there was a heart attack, and then it ruptured. And so now all of this color is all blood flow that's flowing back into the left atrium and towards the lungs. And again, causing that fluid in the lungs and that shortness of breath. I mean, it's very understandable why the patient is so short of breath. Okay, so everyone, I hope you're not eating dinner. This is actually a gross anatomical specimen of a papillary muscle. So this is right at the top here. This is a mitral valve. And one thing that I love about the heart, okay, guys, I'm going to nerd out here for a second, okay? So one thing I love about the heart, when you're born, you are born with these valves or one-way doors that are paper thin. Can you guys appreciate? I mean, this is actually really quite thin. And see these little structures that look like threads? They are literally as thin as dental floss. And these valves stay intact and work for up to 100 to 110 years because you know, on the news you may see, or on your feeds, your news feeds, you may see things like, oh, you know, the oldest person in the world, 100 and something years old, but they literally function for that long. So it's really incredible how our bodies are made. But if you don't have enough blood flow to a muscle, the muscle can rupture as it did here. And of course, this patient or this heart did not do very well. And this just shows that muscle that ruptured, which ended up causing that kind of revolving door where the blood flow went back into the left atrium and into the lungs. So what I call this is a series of unfortunate events. If any of you guys are Lemony Snicket fans, you know, then this is really, truly a series of unfortunate events. And so what happened is one of his coronary arteries, in this case, this was the right coronary artery, so there was an occlusion there. So there was not enough blood flow down that coronary artery to supply that muscle of the heart. So the man suffered an infarct, a myocardial infarction, also called a heart attack, of the specific area of the inferior posterior wall and the posterior papillary muscle, which is that picture I just showed you that ruptured. So the papillary muscle ruptured, which then led to severe regurgitation. So these are just some terminology that we use. Severe mitral regurgitation. Mitral is the valve. Regurgitation means it's flowing in the wrong direction. And then that leads to pulmonary edema, which is a fancy term for fluid in the lungs. So that is actually my case. And I just wanted to say a few more things about cardiology just because I love it so much, if you guys couldn't tell. I had someone say this to me when I was a medical student, and it ended up being the chief of cardiology that I worked under for quite some time. He said to all of us medical students when I was a first year, and he said, you know, why wouldn't you want to do cardiology? That's where all great things come from. You look around you and people say, you know, home is where the heart is. And there's a grateful heart. And he's so good hearted. And there's all these wonderful terms. He said, that's why you should go into cardiology. I'll give you a few others here as well. You know, blood doesn't bother me, as we just talked about. If blood bothers you, then maybe this is not the right area for you to go into. But blood doesn't bother me. But there are other things that lead me to think that cardiology is the best. One is if there's an infection, it is very well contained. So endocarditis or any infection of the heart, very well contained. It is not a gaping wound with big infection that you are dealing with. Some of you may like that. If you do, that's amazing. But infections are well contained. Blood is typically sterile, meaning there's not typically infections within the blood. And then also the heart is where all good things are and what all things are attributed to. So with that, I will end my slideshow there and just argue that cardiology is absolutely the best.
Well, I'll tell you, when we are covered up in chest pains in the emergency department, we 100% agree with you. We 100% agree with you. And I know Gil feels the same way. What a great pair of talks. This is just absolutely wonderful. I wish you could see all the very kind compliments that are coming in chat. Do you all have enough energy for 3 or 4 questions? We kind of skipped over our middle. I've been hogging so much of your time. Cheyenne, can you pick 2 or 3 questions, 3 or 4 maybe, to ask our guests, please?
Sure, of course. So I found one earlier that actually kind of seemed pretty important here. One of the questions we got was, as a woman in medicine, do you feel like your biological clock limits your choices, like specializing in something with a shorter track because you have to start a family?
That's a great question. It's a question that I spoke with a woman just a couple of days ago about this, because I sometimes think that the messaging around that question is misleading. Because I don't want to give people the impression that you can have everything at every moment. You can have everything over the span of time. And so it's all about planning and timing, that both of us are married and both of us have families and they're healthy and growing, and we love them and they love us. And yet we both have careers that are very busy, and spouses that are, I think they're happy. But I think that it speaks to the ebb and flow of life. And it's like everything else that you're going to do, is that there will be a season when you are doing something that, you give more time to be able to have your children. And then you'll change your life at work, and you'll shift back at another time that you'll be able to focus a little more on work. But it allows you to kind of do some of everything as much as you want to over the course of your career. And so my answer is yes, you can, over a time period.
Yeah, I think that's, of course, wisdom from Dr. Nesbitt. I also want to approach it a few other different ways that I just want to say a few words about. One is the landscape is changing significantly over time. There's this wonderful woman named Dr. Nanette Wenger, who is really the pioneer of discovering women's heart disease. And she showed a slide at the American College of Cardiology sessions a couple of years ago during the keynote speech. And it was a slide that showed, it said, how to cook for your husband's heart health, from the American Heart Association. I mean, that shows you where we were, and that was not that long ago. So we have, the landscape is changing. And we have a colleague, Dr. Nesbitt and I have a colleague, Amit Kara, who used to be the program director for cardiology. And he says, he doesn't say there's never a good time to have a kid. He says, there's never a bad time to have a kid, because it's a child. So I think the landscape is changing. I also think that everyone's family looks different. I know of a lot of different families that the husband stays at home or the husband is part-time. And I think that there are multiple different ways that your life can look like. And so I think I also want to be very careful to say that as a woman, yes, we are biologically the ones that can carry children, but also there are many different ways that your life can look like. And I also have to say that the men are stepping up, in terms of caring for kids, doing the work at home, and it's more shared responsibility. And it's because the newer generations are doing such a wonderful job at being true partners. So I just want to throw that out there as something to think about. I wouldn't trade it for the world. I mean, my kids are just phenomenal. Don't tell them I said that.
You should know that about 50% of all medical schools across the US are women. And so the field, every field is changing dramatically, because half of the graduates from medical school are women. So yes.
Absolutely. And
right.
Yes. Families can look all different ways.
That's
So
right. Well, thank you for
you have 350 kids listening to you. So at least the good news is you got your education, you've got a job now, and you don't have to study anymore. Is that right?
Oh my. No, this is a lifelong journey. It is lifelong learning, because, I'll say about 75% of what I learned in medical school way back when is no longer pertinent, except for the anatomy, because there has been so many more new findings around medicine, new therapies. Some of the things that we used to do are absolutely obsolete now. And so in order to stay abreast and up to date, it's always learning new things, always incorporating them into your care of patients. But the essence of it, the empathy, the care, the comfort is a part of medicine that will never go away.
Agreed completely. I mean, I share that with my learners. I tell my learners all the time, I said, before I start CCU, because before I attend in the cardiac care unit, I always read back over lots of different things that I don't use on a day-to-day basis, when I'm not in the ICU. And so I think it's also important that we normalize, the fact that we, have to always keep abreast and we have to work at it. We are not machines. And so, I absolutely, it's a lifelong practice. That's why they call it practice.
Yeah.
We are always practicing.
That's so absolutely true. And actually, I was just sort of pimping you a little bit on that, because all the folks listening, you've got to know that you don't reach a point after training where you've learned everything. Indeed, medicine is changing logarithmically, accelerating in its rate of change. For example, I knew a little bit about the immune system when I finished medical school in 1976. I've studied more on COVID this past year about anything, and I am astonished what I've learned about the immune system that I just simply didn't know. So if you're going to do this for a line of work, you're going to have the best way to think about it, and I'll shut up with this, is that as you're seeing patients, when you find something you don't know, look it up if you can possibly do it at that time. And then be on the receiving end of various sorts of things through your email that are sent to you that, for example, I get New England Journal and JAMA and some others every day, and I read them every day, committing to anywhere from 2 to 4 hours a day of ongoing study, because it takes that to do that. Part of it is being in an academic setting, and I'm around very smart kids, who push me, but still it requires that to keep up. And then one last sentence, and what Shauna said, and you too, Melanie, it's all about the fact that this is a people business. What doesn't really change is just loving your people at the bedside. Some patients are awfully hard to love, but patients refill our cup every day.
Yeah.
Let's take one. Please, Melanie, I'm sorry.
There was a comment about that, and I just think that was such a wise question. Not, when I say wise question, I mean, it's intuitive if you're not already taking care of patients. And said, I think the question was, do you ever get angry with patients? I will tell you that as much work as I do in terms of studying for tests and making sure that I know my knowledge, I've had to do as much work, if not more work, on a personal end of, making sure that I'm the best person I can be. And I think some of that is really involved working on listening to Brene Brown and reading her books. And I think a big, huge piece of becoming the best physician I can be is also figuring out how to cope with difficult situations like frustrations, et cetera. Because at the end of the day, these patients are vulnerable, they're sick, they don't feel well. And it is up to us to always, choose the right course and choose the higher road. So yes, even when patients, if you get frustrated, it's always up to us to be a good leader and a good role model, and also remember that they're sick.
Ladies, I think we're going to give you a break. We bless your sweethearts. You've been going almost 2 hours, and we are so very, very grateful. The humanity, the skill, the love, the dedication, and the hope that you've sent along to almost 400 pre-health kids tonight, students, is so very deeply appreciated. And we are honored, we are edified, and we are intensely grateful. And we would love to have you back. Shayan, do you want to show them how to take the exam tonight?
Yes, I will. So actually, I think Reagan was going to explain that. I have the slides pulled up, so let me go ahead and share my screen, and I'll let Reagan explain that. Here is the slide on the quiz.
So we recently just switched last week to a new quiz platform called Firebox. And so we are no longer using a PIN or password, which is a miracle. And so you just need to scan that QR code on your phone, and it will take you right to the quiz. If you don't want to deal with the QR code, or if you don't have an iPhone or a smartphone like Dr. Fowler, that is totally fine. We will also send out a link to it in our emails. We'll post it to our Instagram, and we'll also post it to our website. Did I already say emails? I think I did. Did I? Whatever.
Maybe, I don't know.
We'll also put it in our emails if I didn't already say that. And I think that's it. You'll have 2 attempts and it will be due next Thursday at 6:59 since we had this session today on Thursday. So hopefully that is everything.
We're just so very grateful for your kindness and your humanity. So thank you so much.
Thank you. Thank you for the opportunity. That this is what I've always wanted to do, was have an impact. And in as much as my impact, I thought I would only touch the people in my small neighborhood. Being able to do this allows me to touch people all over the world. So thank you, and best of luck to all of you.
And publicly, Shauna and Melanie, thank you so much personally for the doors you have opened for me professionally. On an educational level, I learned from you, and I just thank you for the opportunities you have opened up for me personally to engage young learners at our institution and beyond. So really, really grateful for that.
Thank you.
Thank you, Dr. Salazar. Thank you, Dr. Nesbitt, for asking me to join you. And you all, seriously, just go forth and pay it forward. It's an honor.
Great.
And thank you both so much. So all of you, thank you for coming tonight. We look forward to seeing you next Tuesday, where we'll have another exciting show for you. Please remember, virtual shadowing will be here as long as you keep coming back.